Good evening, everybody. Welcome again to this IAM conclave. This evening we have excellent speaker with us, Dr. Soumitra Rai, and the topic is equally encouraging, and it will be too interesting to discuss the topic. While coming to the hotel, I thought I am the moderator, and the moderator's job is to invite questions, to encourage everyone to ask more and more questions. And I was thinking, this is such a topic that I have to work hard on stopping questions. Let's hope I will be true. Now I invite Dr. Soumitra Rai to start his speech. Dr. Soumitra Rai, please.
Good evening. Thank you, respected Chairperson and Dr. Dilip Kumar. Thanks to all the audience. My most sincere, respectful homage to Mr. Indrabadan Modi, whom you have already heard and seen in the video clip. Actually changed the pharmacological face of post-independent India. We had many such great entrepreneurs in 1950s and early 60s, but unfortunately don't see such kind of people so often nowadays. We have to search our soul why we can't see this kind of people anymore. This concept of polypill and polycap is not new. And even this particular preparation is not new. It's already in the Indian market for the last 4 years. So today is kind of a celebration of the innovations that this company has done in the segment of cardiology, segment of chest medicine, segment of oncology. But focus is on the cardiology today. So without wasting further time over here, let's see what we have got to share here. We know that cardiovascular disease is very, very well known nowadays that is the #1 cause of death globally. It has far outnumbered infectious disease, far outnumbered cancer, accidents, suicides, everything. It represents 30% of all global death in 2010. In cardiovascular disease, the major contributor is coronary heart disease, closely followed by stroke, then peripheral vascular disease, and congestive heart failure and arrhythmias. 70% are primary events, 30% are secondary events. So the implication of saying that is that the role of primary prevention is immense in the community, so that the first cardiovascular event can never happen. Or even if it happens 1 decade or 2 decades later in life, rather than in the age of 50, we better have a first heart attack at the age of 70 or 80. At least we can do that. If we see in a sort of real estate map, as if you are going to buy a flat, I like this slide because it's a sort of new slide. You see the main master area, whether you make it a bedroom or make it a drawing dining space, is ischemic heart disease in your life premise. And this is COPD. It is a morbidity. In India, ischemic heart disease, cerebral vascular disease were the leading causes of premature death in 2010 in terms of number of years of life lost. And if you see, we are so much concerned about ovarian cancer, breast cancer. These are at most servants' quarter or loft like that, not more than that. So the Lancet, the study published in 2004 called Inter-Heart Study. We all have heard of it many times, but let's recapitulate. Exponential rise in infarction with added risk factors. If you see that exponential rise in heart attack with smoking is about 3 times more than non-smoker. For diabetes about 2 times, for hypertension about 2 times. So if a person is hypertensive, diabetic and is a smoker, his risk should be 3 plus 2 plus 2, that is around 7. But actually the risk is around 30. So it is not a arithmetic progression, it's a geometric progression. One risk amplifies the other associated risks. If we add ApoP-ApoA ratio and all four, it comes to around 250 times more, astronomical figures. So basically we need to address all the risk factors, whether we are diabetologist, whether we are cardiologist, whether we are general physician. I cannot shun my responsibility being a cardiologist that I don't check the sugar. I am not concerned about your sugar. As a diabetologist, he can't shun his responsibility saying that I don't check blood pressures. So everybody has got a responsibility because ultimately we have to protect the whole patient, not a part of it. IHD risk more than doubles, and then the factor of age comes. If you see, irrespective of men and women, as the age increases, the risk increases. Of course, that is quite natural, and we are happy that the curve is like that. A person, if it would have been unfortunate if the curve would be like that a 20-year-old man will have a heart attack, an 80-year-old man won't have a heart attack. It is a natural elimination process of nature or God. So we have got nothing to say against it, but we can reduce the curves. We can keep the trend down. I am completely agreeing with the teleology that the curve should be like that, but the absolute values can be reduced, even in elderly. That should be our goal. There was a field study which took place in all types of countries in the world, and India was selected as a low-income country along with some obscure country over here in Africa. So you can be proud of that you are chosen as a low-income country. And there are middle-income countries and there are so-called high-income countries which is now down in debt, but they are high-income country. So what Pure study published in 2009 showed, prospective urban, what is Pure? It's not something with sanctity, but it is prospective urban-rural epidemiology study. And what it showed, this study aimed to assess the prevalence, awareness and control of hypertension worldwide by measuring blood pressure, simple thing. 5 continents, 17 countries, 528 urban and rural communities, and some astounding number of people, 153,000. No problem because you are just going to check the blood pressure. So what did they find? That percentage of people, it is a very simple study, but of immense consequence. You see, its a formulation is very simple, but it's a nice study. Percentage of people consuming 4 key proven medications. Patients with coronary heart disease or stroke. So the highest risk category in the society of dying of a cardiac event, patient has already have a heart problem or a stroke. And we know that they should take an aspirin, they should take a statin, they should take a beta blocker, and they should take a RAS blocker, unless there is contraindication. So that is a sort of axiom. So are they doing it? About 60% patients are taking all the drugs, 50 to 60. This is antiplatelet, this is beta blocker, this is ACE inhibitor, this is statin. In upper income, lower middle income, low income. So as the income group decreases, the consumption rate also decreases. That is in urban and that is in rural. So rural is not too bad, but somewhat lower than urban. So that was a very appalling figure. How to address this problem? So most urban societies have elevated levels of risk factor. More than 99% of controls in interheart had at least one risk factor. They are not secondary people, they are primary prevention group. 90% of individuals in the UK, above 50, there was elevation of cholesterol, BP, or at least one traditional risk factor. While the focus has been traditionally on applying CV prevention in the highest risk individual, most CV events occur in these lower or middle risk groups. So we can say again and again that prevention is better than cure. We know how to prevent it. At least we know partially how to prevent it. by reducing the pressure, by reducing the cholesterol, by reducing the platelet activity, by reducing sugar and reducing body weight, stress, body habitus, exercise capacity, etc. So there is no paucity of intervention, still CVD is on rise. Why? Risk reduction associated with individual intervention. We know that risk reduction is effective. Like if you reduce blood pressure, MI reduces by 25%, stroke reduces by 40%. If you reduce cholesterol, again MI reduces about 25%, actually it is more, figure is around 40%, stroke reduction is also around 40%. Similarly with platelet aggregability. So if we reduce everything, we can at least reduce 70-80% of risk. It was published in Lancet 2005 that again, not arithmetic, but geometric calculation. 10% reduction in BP and 10% reduction of total cholesterol reduces 45% reduction of CVD. So again, it is not 20, but it is 45. So if we control, just like when the association of risk multiply each other, similarly, if we reduce the risk together, they multiply their beneficial effect also. It's not just simple addition. So this is very gratifying. So it is very gratifying to treat a patient and to reduce the risk. Cumulative risk reduction with combination therapy. 2-year event rate, if we think that if we don't give anything, on top of that if we give aspirin, 25% reduction, beta blocker 25, lipid lowering 30, ACE inhibitor 25. So at least 75 to 80% we can reduce by simply these 4 implementation. Secondary prevention, definitely. Primary prevention, yes. A strategy to reduce cardiovascular disease by more than 80%, it is in a World and Law paper, it's a very old paper, 10 years old, but it was very interesting. If we reduce LDL by statin, pressure by 3 class of drug with half standard dose, serum homocysteine by folic acid, platelet by aspirin, and combine them, at least 80 to 90% of IHD and stroke can be prevented. It is a very old concept, but how to implement it? The problem is in the implementation. Effect of the drug combination on mortality, about 30,000 patients with IHD, there is a BMJ paper, only statin reduces the odd ratio to 0.5, ACE inhibitor to 0.8, aspirin about 0.7. If we combine, it becomes almost 0.1. So that's how for last 20 years it is told that all acute coronary syndrome patients, when discharged from the hospital, they must have aspirin, statin, beta blocker and ACE inhibitor. And if you do not have one of these in your discharge certificate, then you have to have a justification line. Beta blocker not given because of this. It is as important as that. You cannot be silent on that. You have to prove that you have thought of giving it and you are not giving it because of so and so reasons. So these 4 drugs in all secondary prevention is mandatory. There is no question, no doubt, no debate about it. The debate comes, the problem comes here in the compliance. What happens when all these patients with all your good effort and intention is discharged from the hospital? Within a month, 1/3 of patients discontinue one or the other drugs. And the reasons are multiple. Social, economical, psychological, many reasons. But only 2/3. But that's not a bad thing. At least 2/3 are taking all the 3 drugs. But in 1 month. Can you imagine what happens in 1 year or 2 years? Because these are to be given for indefinite period, 5-10 years. Why patients do not adhere to the therapy? There are certain issues come up in various journals at various times. Once is treatment complexity. This you take before breakfast, this you take after breakfast, this you take at 7 p.m., this you take after dinner, this you take after lunch. The patient is totally confused. Number of daily pills. There are very elegant papers in various journals. that as the pill number increases, compliance sharply declines. You can see an antibiotic given 3 times a day, a course of amoxicillin clavulanate, 15 tablets in 5 days. If you take yourself, I do not know how many of you will see the strips empty after 5 days. You will see 2 or 3 are there still. So I forgot something somewhere, sometime. That's why if it is twice a day, you will forget 10%. If it is once a day, perhaps you will complete the course. So that is as simple as that. You can test it yourself. Number of chronic condition. This is very important in Western countries where there is not much of social help or home help. Like a person of rheumatoid arthritis, a person of COPD, person of impaired mobility. They cannot go and procure their medicines. Because of our social structure, people usually support each other and give medicines. So this is not a big problem in our country, but this is a very big problem in Western countries. Non-compliance, of course, affects survival. If you do not take all medicines or some medicine, your survival will definitely change. It need not be proved. So the concept of Polycap development milestone, if we see, 2003 and 4, as I said, 10 years ago it came. Literature review and new product development started. In 2004 there was some protocol made. Then next 2-3 years, TIPS-1 clinical trial was completed. In 2009 there was IP filing. It was published in Lancet in 2009. 2010 it came in Indian market. 2011 TIPS-2 clinical trial completed. 2012, only last year, got the Wellcome Trust Award, and the TIPS-3 started. It has already recruited more than 1,000 patients. So what actually they are giving in Polycap? So Polycap is a concept, Polypill is a concept. Many companies are launching it, and yet to launch many other companies. We might also discuss the pros and cons of this particular preparation, which will come out during the discussion or interaction. But first find out what it is there. 3 antihypertensive of hydrochlorothiazide, atenolol and ramipril, and simvastatin, and aspirin 100 mg. That is the structure of the Polycap. Who can be benefited? Of course, in secondary prevention and in primary prevention. Is it just combining this into a gelatin capsule? It's not as simple. Then all other companies would have brought it. You have to see the bioavailability. And I don't go into this slide. Bioavailability, if you give the individual molecule, vis-a-vis in the Polycap is equivalent. Of course, otherwise it won't have got the DCG permission. The TIPS-1 trial, what was it? It was a 9-arm randomized trial with 50 centers in India. Kolkatta was also a center. Included more than 2,000 individuals with cerebrovascular disease, of middle-aged and elderly people. There was 3 months treatment and 4 months follow-up. And the impact was on clinical parameters and some biochemical parameters. It was a safety and tolerability study. And if you see, it is not an arbitrary choice. They have gone through this TIPS-1 trial by various combinations. Just aspirin, just simvastatin, just thiazide, and mix and match of all things, and ultimately the Polycap, and there are a good number of patients in each arm. And what did they find? Of course, there's nothing new. If you add 1, 2 or 3 blood pressure medicines, the blood pressure will be lower. Nothing new in it. TIPS result, impact of atenolol arm versus Polycap in heart rate. It is entirely by the atenolol effect, the heart rate reduction. Of course, ramipril and hydrochlorothiazide are not going to reduce your heart rate. Rather, hydrochlorothiazide can increase your heart rate. The impact on LDL with separate simvastatin and this group simvastatin is same. Similarly, the platelet reactivity is the same. And safety comparison is same. There is, of course, you don't expect any new or novel side effect from known people when they come together. So that was TIPS-1. What is TIPS-2? It is a randomized double-blind trial with 27 centers in India. Again, Kolkatta was center. More than 500 individuals with history of CVD, so secondary prevention arm, aged 40. randomized to single or 2 dose of Polycap. This is interesting. OD dose or BD dose, or low dose and high dose. Participant in double dose group also received some potassium supplement because of the high dose of hydrochlorothiazide. And 2 months treatment with 3 months follow-up, and impact is on clinical parameter and safety and tolerability. And what you see that reduction of coronary disease 62 versus 69 in double dose, and stroke reduction is 14 versus 57 in double dose. So 4 out of 5 deaths from CV disease occur in developing countries. Millions of patients at risk throughout the world, with 50 million stroke and 50 million IHT. 275 million with no previous illness, but they are at risk. And of those, 45 million are in India. So there is a huge scope of preventing these people experiencing their first episode, including us. So this is a brief presentation which summarizes that Polycap is a late-stage near-to-market opportunity which addresses the largest disease market in the world. Polycap has shown efficacy and safety in 2 large randomized potential trials. Sorry for the spelling. Market trends show an increased use and acceptance of combination drug in CVD. Very encouraging communications with the US FDA on the regulatory pathway of the Polycap to approve. Just to finish it off, you know that Salim Yusuf is a great proponent of this combination of drug. And I want to finish with my own observation, which I didn't put into slide, is that there is no argument that titrating the dose, titrating the molecule, titrating the timing of giving it has got no substitute. When you give which molecule at what dose for an individual patient has to be on basis of monotherapy. There is no debate on that. That is an idealistic world. What happened in realistic world we have seen that by doing that, the patients land up in getting nothing or taking nothing. So something is better than nothing. If that is the motto, then all combination things come. Polycap is just an extension of the theory of combination therapy. What is the fundamentals of combination therapy are 2. Number 1, to improve the compliance. Number 2 is to decrease cost. There is nothing else, and there is nothing more and nothing less in a combination product. And all Polycap, Polypill is after all a combination product. So its selling point to us, to the physicians, is patient compliance and cost. There would be argument that why this molecule is chosen, why this dose is chosen, how can you give it all after food or before food or in the morning or at night or whatever. These are everything, it is an ideal world, but here the trade-off is all those things. But the trade-on is patient will take at least something for his secondary and primary prevention at a reasonable cost. Then we can have discussion on it. Thank you.
Thank you, Dr. Samitra Rai, for the wonderful lecture and for so beautifully explaining the concept of Polycap. And it's indeed the cost and the compliance. These are 2 motivating factors behind the concept of Polycap. Now, invite questions. I hope there will be a lot of questions. Why atenolol? Why not metoprolol? Why dosing? Everything. So we'll start with the. Can you hand on the mic there? Please introduce yourself before putting a question.
I am Dr. Ramshu Prakash Shah. I like to know what group of beta blocker is appropriate for cyst. Whether there is nemibolol, whether there is metoprolol, whether there is bisoprolol, whether it is atenolol.
For hypertension and coronary artery disease, all beta blockers are approved. Atenolol, metoprolol, bisoprolol, carvedilol, nebivolol, all the 5. For heart failure, atenolol is out. It's carvedilol, bisoprolol, and only long-acting metoprolol. Nebivolol is plus minus. So if our segment is hypertensive or primary prevention or even ischemic heart disease, atenolol is a fair choice. There are a lot of adverse publicity against atenolol that was more commercial than scientific. Nobody has shown anything that atenolol increases ischemic heart disease. What they have shown as a class of beta blocker did not reduce coronary artery disease events as much as amlodipine and ACE inhibitor. Then the whole beta blocker lobby started pursuing against this revolutionary statement about 8 years, 7 years ago. And some lobbies who had parents still. So again it suits if you give this combination after breakfast. Again there is hydrochlorothiazide, so you cannot give it in the evening or night. So it's better to give the whole thing just straight away after breakfast. If there is anything supplement you want to give, keep it for the evening. As simple.
Just one more question. From the Interheart and Eurosapphire, I was just about to leave, I just came back from our book. So Eurosapphire, book premise, and you talked about pure. So everywhere it boiled down to the fact that the people who are above 55 years of age, 90% of the CVD deaths occur to these people. Now more Europe-America based data. And if you're above 55, that's the strongest discriminating factor. Plus one additional risk factor, 90% of them die. Now for our context, diabetes capital of the world and everything is happening 1 decade earlier, and diabetes is a cardiovascular disease. So when is the optimum time that one can think about, instituting this drug to a human being?
Above 40.
Great.
Anybody above 40.
Great.
Sir, we have the experience of Polycap to control Helicobacter pylori. But after some years, we got confused because various multiplication and punctuation combination came up. So we are very much confused. I don't know whether we will be again confused this Polycap concept, because so many companies will be coming out with all the multiplications and combinations.
Helicobacter pylori, Polycap was not actually Polycap. It was a kit. It was a kit. There are 2 tablets. Some people give 3 tablets. It's sort of cheating. It was not a cap. It was a kit which there are 2, 3 because they are not biocompatible, not at all. So that doesn't really translate anything to do with Polycap. As I said, Polycap has got problems initially, but now people are accepting Polycap worldwide. It is getting approval by all the authorities in Europe, America, as well as in India. So perhaps they have looked into it, and perhaps they are satisfied with the performance.
Is there any criteria or any parameters to assess the dosage of atrovascular statins? That is, whether it is 10 or 20 or 40 or anything else. Is there any parameter? Is there any?
I couldn't get the question, sir.
I am telling that you have had Polycap, it says simvastatin 20.
20, yeah.
What is the problem?
Yeah.
Wow.
Okay. Now I am asking you that is there any parameter to assess what should be the dose of atrovascular, whether 20 or 40 or more?
If you want to substitute simvastatin 20, your atorvastatin equivalence is 10 milligram. This is 2:1. I think Polycap is already being distributed outside, so there is a lot of enthusiasm about that. So should we call it a day, sir?
Now, finally we conclude this session. Thank you all for the nice interaction we had. And finally, the chairperson will give us the remarks.
Oh no, I have no remarks.
Not an issue here because amlodipine is not there or hydrochlorothiazide they are not expected in in this particular case. I don't think anything against atenolol at all. It is still a very appropriate drug in India because it is cheap, it is effective, it is long acting, it is well tolerated, it is excreted by urine, nothing much to do with the liver function. It's a good one.
Second question is that the Polycap contains ramipril, dihydrochlorothiazide, and the simvastatin and beta blocker. Along with
you told me that you just tell that potassium supplement is required. Now, two questions
In the double dose.
Two things is here. Number one, if Ramipil may cause cough, then how the dose can be adjusted, number one. And number two is that as Polycap itself contains all these things. And lastly, because Ramipil is potassium sparing drugs, potassium supplement, how much potassium supplement is required?
The question to first is not only Ramipil and cough. If there is a side effect of any of the 5 components of a polycap or polypill, you have to simply stop the polycap. There is nothing about it. You have to stop it. You have to segregate that drug out and find out some other combination where 2 + 1 or 2 + 2, anything you can give, or 4 drugs separately. As simple as that. I mean, you can't define polycap in that. Secondly, the interaction of a diuretic and a RAS blocker. What will happen exactly in the potassium level in a particular patient, nobody knows.
Yes.
So that has to be individualized. You have to check the potassium, whether you require potassium supplement or potassium declining drug. That's the time will tell, and that patient's blood will tell. Nobody else can tell.
And another thing is that though it is not related with this seminar, the patient having diabetic in oral antihyperglycemic drug, oral hypoglycemic drug, but after CABG, whether insulin is only the choice or he may come to oral hypoglycemic drugs.
After CABG, a diabetic patient should have only insulin. I think there are good diabetologists here to answer this. I am not in an appropriate.
This is no hard and fast rule to give only insulin to patients who have undergone CABG. So we can give all sort of OHs there. And coming to one point where ACE inhibitors were being discussed, I would like to highlight a few important aspects. We all write ARBs like anything. Telmisartan, the sartan groups, the olmesartan, losartan, and now it has become the #1 choice of all the physicians, more or less, as an antihypertensive. We start with telmisartan and olmesartan. But I would like to highlight here the recent meta-analysis which have been published in European Heart Journal and also in Lancet, that these ARBs, they are not going to reduce the mortality. The ACE inhibitors, on the contrary, any ACE inhibitor, Ramipil, perindopril, enalapril, if you are giving, you are reducing the blood pressure, you are keeping the blood pressure within the normal limits, and it is reflecting in the total mortality. End points are coming down. But with ARBs, we are only seeing the reduction in blood pressure, but the mortality benefit is not there. These have been, the discussion of today's, these have been highlighted like anything in recent guidelines, recent literatures. So ARBs of late have become, in future, near future, I don't think it is going to enjoy the same position as it was enjoying for the last 5 years. So in Polycap, being Ramipil being there, I think it's a very good option if you are getting this. And cough, especially cough is a very strong factor for us. They say in Asians, on the contrary, 10% they say they claim that 10% incidence of cough is there with Ramipil. But in Asians, especially South Asians, we have 30-35% incidence of cough. And that's the reason why we have moved towards ARBs. Most of the, like 33%, means 1/3. Out of 3, 1% is coming back with cough. So we are moving towards ARBs. But still, we can't, nullify the benefit which we are getting with Ramipil, and we have to start with this drug. So if the combination carries Ramipil, it is very apt combination. I think more questions if... Yeah.
About that question on diabetes and post-diabetes.
It's about the issue. May I have the privilege
just before it's about the ischemic preconditioning. There are papers saying that glibenclamide has this problem with ischemic preconditioning. We know that once you have a heart attack, once there's a scar, and the other arteries which have not been kind of addressed at that point in time, only one graft was perhaps put in. The native vessels, we know that diabetes causes diffuse coronary artery disease and all the vessels are affected usually. Now, if this mechanism of ischemic preconditioning due to the closure of potassium channels which happen with the OHS, they close the potassium channels on the beta cell and thereby depolarizes the cell membrane and opens the calcium channel. Calcium comes in as an influx and then squeezes the insulin granules from the Golgi complex and brings it out through the membrane to finally release it, as a first pass, first secretory effect or the second secretory effect. Now, this happens even with the cardiac cells. You have sulfonylurea receptor 1 and sulfonylurea receptor 2 in cardiac cells, 1 in pancreas, beta cells. Now, if you close the potassium channels in the cardiac cells as the sulfonylurea is supposed to do, then what you do is you actually stop this ischemic preconditioning mechanism. And there were papers saying that glibenclamide does that and it's not as good as that. Then came glibenclamide which said that 140 kilodalton is the target for beta cells and 65 is that for cardiac cells. So a lot of debates happened. Glycoside came in and glycoside actually won the battle out of a meta-analysis. But now the problem is if you actually apply nicorandil and groups like again the potassium channel driven forces, then glibenclamide causes problem. Otherwise, the meta-analysis shows that glibenclamide is not as bad as was told. Like Shomita was telling that atenolol said. And the Lancet paper came out and said atenolol causes more stroke and it created a huge noise. But that's actually not, effectively not true. Similarly, glibenclamide, the best, kind of drug in terms as competitive to atenolol is again still the choice. If you survey the country.
Well, we'll be more confused. Diabetologists are so much academicians that's what I didn't become a diabetician. Excellent deliberation, but let's keep it at the ground level. Any other question? Thank you. Yes, sir.
Polycap is being prescribed. How much in a study analysis the hydrochlorothiazide can raise the blood sugar in patients, and whether the other diabetes like ortholid or indapamide would have been a better choice?
Yeah, very nicely, that's why Devashish is so elated about this product. Of these 5 molecules, 3 are diabetogenic in a polycap. Hydrochlorothiazide, beta blocker and statin. All are diabetogenic. So that's the trade-off. We cardiologists generate patients for diabetologists by giving these drugs. It's a mutual symbiotic relation, better not disturb that. Any other question?
I just want to say, when the Polycap concept came, these drugs were actually used, but I think a lot of companies have brought newer beta blockers in a molecule with the newer statins. So I think that the concept will change, and as you mentioned that atenolol is very cheap.
Yes, that area Monojita needs some elaboration. This is very, very important. Firstly, of course we would like to give the latest molecule. All companies would like that. There are 2 problems. One is the compatibility problem. Whether if you combine a long-acting metoprolol with an atorvastatin in a same gelatin-coated capsule, some are lipid soluble, some are water soluble, some are absorbed with food, some are absorbed without food. So if you saw, I didn't show all the slides. It is not as easy just to buy the pills and put them in a gelatin capsule. So you have to check the biocompatibility of one component with the other. So most ideal molecule may not be biocompatible with the other 3 or 4. That is number 1. Number 2, this company as well as other companies are trying various other combinations. At least they are trying 7 or I was just discussing with the people. They are trying another 7 or 8 combinations including amlodipine, including atorvastatin and so on and so forth, including ARB, you might see Polycap 1, 2, 3, 4, 5, like some other companies have already brought 2, 3, 4, something like that. So it is not the end of the road, it's just a concept. There is of course scope for improvement and polishing and to make more than one Polycap which can suit one patient or the other. Of course it is a very, very valid point.
Dr. Kumar, as you have been saying that AC inhibitors are going to replace ARB, but how come it is the antihypertensive property? Do you think that they are at par? They are definitely not at par. ARB, definitely they are having high potency so far antihypertensive properties concerned. Number one. Number two, so far this fixed dose combination is concerned, how can you prescribe it? It may be applicable only for primary prevention. But whenever you are supposed to risk stratification, say having a heart risk score, how do you give a fixed dose statin to, coronary artery disease or only the risky population? So that way, these are the, I think, demerits of this fixed dose combination.
Yeah, very right, sir. Questions are very valid. And ACE inhibitors are not going to replace ARBs. These are the ARBs which have replaced ARBs first, the ACE inhibitors first. But of late the results with ARB is that okay, we are reducing the blood pressure, whether it is reflecting into the mortality benefit or not, or the endpoints or not. So this has been a little contradictory. And still the time is yet not right to give a proper comment. But things are moving again towards ACE inhibitors, number one. And second point regarding the dosing in polycaps, the fixed dose, it's very still a point of contention. That definitely the dosing is one concern which have to be discussed.
Yeah, here is a fundamental mental block. We need to clarify that also. Once you are giving Polycap, that does not mean you are precluded to write anything else. So it is perfectly justified that you give the Polycap in the morning and give a top-up dose of simvastatin at night, or a top-up dose of lamivudine at night, or add amlodipine at night if the pressure is not controlled. So once you are writing Polycap, that does not mean that you cannot write anything else as per need. As very validly said, we might need simvastatin 40. In Polycap it is 20. So give the Polycap, give another 20 mg simvastatin. What you ensure, if the patient forgets or does not take, that compliance thing. At least he has taken his Polycap in the morning and 20 mg simvastatin is in the system, which is better than 0 mg but which is worse than 40 mg. So it's always, as I said, the key note is the compromise. It's a compromise treatment, compromising for compliance and cost. So it is not substituting an idealized, individualized treatment. That has to be kept in mind.
So then what should be the appropriate timing for administration, Mr. Polycap?
Yeah, that's an excellent question. If we again think of the compliance, most people are comfortable to take it after breakfast. That's the most compliant time of the day, for the whole day. So we give it after breakfast because most of the blood pressure medicines are given in the morning. Aspirin can be given anytime but after a food, so after breakfast suits. Only thing is that simvastatin is ideally should be given in the evening or after dinner. But if you see the FDA guideline, statin can be taken at any time. I take my statin with breakfast. I don't take it in the evening or at night. Statin can be given at any time, day or night, before or after food. Simvastatin is preferably after food because it's a lipid